Hi, everybody. Dr. Fleischman's going to talk to you about what he does, so enjoy his video.
Welcome to today's lecture, Introduction to Radiology. My name is Matthew Fleishman. I'm a radiologist in a practice based in Denver, and I am the medical director of the Department of Radiology at Swedish Medical Center. Let's talk about the goals for today's lecture. We're going to review what exactly the field of radiology is and how it fits into the other specialties in medicine that you're going to hear about this year. We're going to talk about who the radiologist is, what's involved in their training. We're going to talk about the types of studies that are done in radiology. And we are going to review the fundamentals of diagnostic imaging. Radiology, more properly referred to as diagnostic imaging, as many of the techniques used do not involve ionizing radiation, is the evaluation and study of human anatomy, disease, and trauma using a variety of different imaging methods and technologies. Traditionally, radiologists were involved in establishing diagnosis. Increasingly, radiologists are directly involved in patient treatment using the imaging tools that we have. The radiologist is a medical doctor with extensive training beyond medical school. From where you sit today, it is a long road. 4 years of college, 4 years of medical school. After completing medical school, all physicians undertake a year of internship, hospital-based, to learn how to take care of sick patients. Radiology residency specialty training in diagnostic imaging is 4 years. Almost all radiology residents then go on to do some form of subspecialty training for 1 to 2 years. In total, that's 14 to 15 years from where you are today. It is a long road, but well worth it to enter a fantastic specialty in medicine. The radiologist is often referred to as the doctor's doctor because of our role as consultants to other physicians in caring for patients. The radiologist is directly involved in diagnostic imaging interpretation, but also involved in managing imaging workup. There are many different imaging studies from simple to complex, and they can be expensive and have specific risks. The radiologist is most expert in assisting other physicians to choose the most appropriate study for the question and problems that are at hand. Radiologists must be expert in human anatomy. Radiologists must have knowledge of all branches of medicine. Much of what we do involves surgery, adult medicine, pediatrics, orthopedics, neurology and neurosurgery, emergency medicine, and trauma, as well as oncology, even psychiatric conditions. Radiologists must be expert in the physics of how images are made so they can troubleshoot problems as they arise and optimize images with the lowest possible radiation. Radiologists become proficient in using imaging procedures to intervene within the body using needles and wires and tubes to obtain tissue, to drain fluid, to open and close blood vessels when needed. Because all imaging studies are now digital, there is an intense use of computers and networking in the field of radiology. Learning to interpret diagnostic imaging studies begins during the apprenticeships of radiology residency and fellowship, and then continues on throughout the career of a radiologist. Most importantly, radiologists need to appreciate the appearance of normal anatomy and the many variations of normal that are encountered on various imaging studies. Only then can the radiologists be prepared to identify pathology, abnormalities that we refer to as findings on imaging studies. Abnormalities often have familiar patterns. Common things occur frequently, and have both usual and unusual appearances. Rare entities also occur, and the radiologist must be prepared to identify them in order to establish the correct diagnosis and set the patient on the correct treatment path. Radiologists must be prepared to recognize many emergent problems and findings that require immediate action. And very importantly, the radiologist must not be complacent and satisfied by making one finding. They need to continue to look at the study to make all of the relevant findings, so in order to solve the diagnostic puzzle for the patient. In solving this puzzle, the radiologist may sometimes arrive at a single certain diagnosis or a list of potential diagnoses. This is referred to as ant-many versus differential diagnosis and is the fundamental decision-making process that all physicians go through in evaluating problems that patients present with. This image of an older woman wearing a funny hat, the price tag still attached, is meant to evoke the concept of an Aunt Minnie. Her name was in fact Aunt Minnie Pearl, and she was a famous actress, recognized easily by these outfits. We all have family members and friends who we recognize instantaneously, no matter the location or context, even in low light or at a funny angle. We know who they are, and we're absolutely certain. This concept also applies to radiology and medicine in general. There are many things that we see that we recognize with absolute certainty, and this we call an Aunt Minnie. There's even a website dedicated to this idea where many radiology cases can be seen. We refer to some imaging findings and abnormalities as Aunt Minnies because when we see them, we know for sure what it is. It always has that same appearance. We don't entertain any other possibilities, and we're absolutely sure. It's rather uncommon in medicine to be absolutely sure about anything, but an Aunt Minnie is one of those exceptions. Let's look at a case example of an Aunt Minnie. This is a frontal radiograph of the chest in a patient with left-sided chest pain. Remember, this is the patient's right side. This is the patient's left side. The heart is shifted slightly to the patient's right. Normally, it should be very slightly to the left of midline. We notice that there is an area in the lower left chest that is darker than the remaining lung. This is a pocket of air that has accumulated between the ribs and the lung. And the finding is a left-sided pneumothorax, air between the ribs and the lung. It is a relative emergency. It needs to be treated quickly. And it is absolutely an Aunt Minnie. There is nothing else that looks exactly like that. I want to make it very clear how important the idea of differential diagnosis is. For every finding that is not an Aunt Minnie, there is a differential diagnosis. And this really is what happens in radiology residency and fellowship training. It is learning the differential diagnosis for every single possible finding that could be made on an imaging study and coming up with a rational plan for how to work up and evaluate that abnormality. In daily practice, Aunt Minnies are relatively rare. More commonly, radiologists and all physicians are engaged in the process of differential diagnosis. Differential diagnosis is the fundamental process of medical investigation, where the physician is sorting amongst diagnostic possibilities to reach the correct answer. The radiologist and other physicians, in working up a problem, construct a list of possible diagnoses from the most likely to the least likely based on imaging findings, history, other studies, laboratory studies, physical exam. And they decide how to proceed with the workup. What is the right next test to do? Let's look at a radiographic study to explore the idea of differential diagnosis. These are three images of the hand and fingers. We'll talk soon about how to figure out whether this is the left or the right hand. But for now, it's most important to think about coming up with an organized plan of how to look at an image. I think you should just go up and down the bones to try to make the findings. If you're looking carefully, you probably have recognized that there is a hole or a lucency in the tip of this finger. This is the index finger. These are the phalanges, the proximal, middle, and distal phalanx. On this oblique view, we can faintly see the lucency, and on this lateral view, we can see the lucency fairly well. It's expanding the bone. For me, this is not an Ant Mini. I'm not 100% sure what this is, but I have a list of things that it could be. This could be a benign bone cyst. It could be a bone tumor, benign or malignant. It could be a tumor of a blood vessel. There are blood vessels that run through the bone. This could be the consequence of a heat or a cold injury. Frostbite in the fingers can have this appearance. There are disorders of calcium metabolism that can cause lucencies, holes in the bones that look like this. Infections can have this appearance, as can an old puncture wound. Perhaps the patient is a seamstress who has repeatedly punctured his finger with a needle. The bottom line is that we need to know a differential diagnosis for everything that we encounter that is not an Ant Mini. Before we start looking at radiographic imaging studies, let's talk about right-left orientation and what we mean when we refer to right and left side in imaging. When we look at a person standing in front of us, we know that their right side is directly across from our left side, and their left side is directly across from our right. When we look at imaging studies, we view them as if we are looking at a patient standing in front of us. The patient's right side is on our left, and the patient's left side is on our right. This is true whether we're looking in the chest or the abdomen or the pelvis. Patient's right side is our left, patient's left side is our right. We always talk about anatomy with respect to the patient. If we're talking about something that's in the right side of the chest or body, we use the term right. The exception to this rule is looking at the hands and feet. When we look at images of the hands and feet, it's as if we're looking at our own. So take your hands and put them out in front of you, thumbs together. Your right hand is on the right side, the left hand is left. Similarly for the feet looking down, the right foot is to the right, the left foot is to the left. This rule only applies to the hands and feet. For all other images, it's as if we're looking at the patient in front of us. Let's review the various imaging techniques we're going to discuss today. X-rays are plain films of the chest, bones, other body parts. Mammograms are a form of X-ray targeted at the breast. Computerized axial tomography, also known as CAT scans or CT scans, have revolutionized medicine and are a very important part of radiology. We're going to review magnetic resonance imaging, referred to as MRI or sometimes just MR, an incredibly powerful imaging technology that does not use ionizing radiation. We're going to talk about ultrasound and its various applications, nuclear medicine and PET scans, and we'll talk about angiography and interventional radiology. The discovery of X-rays is a relatively recent event in the course of human history in science and in medicine. X-rays were only discovered in 1895, just 125 years ago, by William Conrad Röntgen. In his honor, radiographic images were initially referred to as Röntgenograms. Fortunately, that has been shortened in current terminology to X-rays or radiographs. Like many brilliant and important discoveries in science and medicine, X-rays were found accidentally. Röntgen was working in his laboratory with cathode ray tubes that were energized by electricity, and in a separate area of his lab, inside drawers, he had photographic glass plates. He noticed that when the cathode ray tubes were energized, the photographic plates developed images of the objects sitting on top of them, and radiographs were born. This discovery truly revolutionized medicine. It was the first time it was possible to look inside the body without a dissection. And Röntgen did win the Nobel Prize for this. This is the kind of equipment that was found in Röntgen's lab in the late 1800s. Here's a picture of William Conrad Röntgen at the end of the 19th century. And this is the first radiographic image of a living human ever obtained. It's the hand of Röntgen's wife. And while we would regard the image quality as relatively poor, this was a mind-blowing image for its time. Modern radiographic equipment, which is all digital, looks more like this. And the image detail that we see on current radiographs is superb. This is the image of a left hand in a child. You may notice that many of the bones have these little caps on the end. These are the epiphyses of the bone in a skeletally immature patient still growing. As the child grows and reaches full maturity, these small parts of the bone will join the longer part, and that's when the time of growth has ended. Let's look at a real radiographic study of the hand. These are 3 views of the hand. Which hand is it? Put your hands out in front of you as we talked about. This is the left hand. Does anyone see the abnormality? Well, the best way to approach an image is to try to be very systematic. Start with one bone, look all the way down its length, then go up the next bone and so forth. I'll bet many of you have recognized the fact that there's an oblique lucency in this bone. This is the 4th metacarpal. Count the thumb as 1st, 2nd, 3rd, 4th. This is the 4th metacarpal, and it has an oblique fracture. Are we done? Well, the most commonly missed fracture is a 2nd fracture. If we look at this image, which is an oblique view of the hand obtained at the same time, we can actually see that there's another fracture. It's hard to see here, but in this more oblique view, 1st, 2nd, 3rd, you can see a similar oblique line in the 3rd metacarpal. This patient has fractures of both the 3rd and 4th metacarpals. It's easy to feel satisfied after making the first finding of fracture and miss the 2nd fracture. Also important to keep going and try to make all the findings on each study. Let's discuss the 5 basic radiographic densities. Density is a physical property of matter. The denser the tissue, the greater the degree to which that tissue can stop X-rays as they pass through the body onto the imaging system. Before we do that, let's orient ourselves to this image. Recall that we discussed the general exception of looking at the hands and the feet as if they are our own. For all other parts of the body, we look at the anatomy as if we are facing a patient that stands before us. Accordingly, the patient's right is on our left side, and the patient's left is on our right side. Think about this as you take your own right hand to shake someone's right hand that stands in front of you. Your right hand crosses to their right side on the left side of your body. We always refer to sidedness with respect to the patient. When we speak in a report, whether it's a radiology report or a surgical report or otherwise, the right is the patient's right, the left is the patient's left. Here, the number 1 depicts the lowest density structure on this image, which is gas. This is gas within the left part of the colon, known as the splenic flexure, because the spleen resides in this location. You can also see air in the stomach, air and stool in other portions of the colon. The next most dense structure is fat. This is fat in the soft tissues under the skin along the right lower chest wall. The next density is soft tissue or fluid. They would appear similar. This is the lower pole of the left kidney. You can faintly see the outline of the left kidney here. The next most dense structure is bone, which contains calcium and stops X-rays to a great degree. This is the 4th lumbar vertebral body. And the densest structure on this image is metal. This is a coin, inside the patient's stomach that completely stops these radiographs, causing the image to be white in this location. Let's look at a radiograph and see if we can make some diagnosis. What anatomy are we looking at? It's always proper to describe what part of human anatomy we're looking at and from what projection. I think you all know that we are looking at a frontal view of the chest. The whole chest is not included. There are parts of the lung that are outside the image. This is portions of the left lung, portions of the right lung, and this is the heart. Does anyone see what's not right? Well, it takes a little while, but you may have focused on this structure here. It's very dense. I think you would say that it's metal density. Is this an Ant Mini or a differential diagnosis? Well, to me, it's a little bit of both. It's an Ant Mini in that it's metal, but it's important now to figure out where exactly it is. How could we do that? A basic principle in radiology is to obtain perpendicular images to localize a structure in 3 dimensions. In this instance, it would help us to have a lateral view of the same anatomy to identify this structure. Here is the lateral view, which now shows us clearly this metal disc. It's a coin in the mid part of the chest. Here we can see the spine. This is the sternum. Here we see the heart on its side. The blacker areas are air-filled lungs. So we may now ask the question, where is it? Can you figure it out? Well, you can, and this is why it's so important for you and for radiologists to have a great understanding of anatomy. If we look here, we can see this black band that represents air within the trachea, the tracheal air column. If you paid attention during anatomy at dissection, you would know that the trachea always sits in front of the esophagus. The differential diagnosis here would be whether this coin is in the trachea or in the esophagus. Are you going to call the GI doctor to help you get this out? Or are you going to call the pulmonary doctor to help you get this out? The lateral view shows that this coin is posterior to the trachea, located within the esophagus. This is a fairly typical place for a coin to hang up near the top of the aortic arch. The GI doctor can take a scope, put it into the esophagus, and grab the coin and pull it out. For small structures, smaller than this coin, they will sometimes push it through into the stomach and it can pass through the GI tract. I would be concerned that this coin is too large to pass through the entire GI tract, and that's why the GI doctor would remove it through the scope. Let's look at another pair of images. What are we looking at? This is a frontal and a lateral view of the chest. Let's think about the various densities. The left lung is filled with air and appears normal. We have the soft tissues of the heart. Soft tissue in the right upper quadrant is the liver. This soft tissue is the spleen. There's air in the stomach. What is not normal? The abnormality is this white area of density in the right lung. You can see on the lateral view that this is in the back part of the lung. Again, knowing the lobar anatomy of the lung, we know that this is opacity in the right upper lobe. Is it an Ant Mini or is it a differential diagnosis? It's a differential because many things can cause this appearance. A lung tumor can have this appearance. Pneumonia can look like this. Trauma with contusion and hemorrhage in the lung can have this appearance. If there was water in the lung from drowning, it could have this appearance. This is where history will help us. In this patient, the history of fever, cough with productive sputum, and an elevated white blood cell count helps us establish the diagnosis of right upper lobe pneumonia. Mammography is a form of X-ray study targeted at the breast. Mammograms provide high-resolution imaging of breast tissue. It's a very imperfect study, but it's the best available imaging test that we have for identifying breast disease. Mammographers look for small calcifications, for masses and distortions of normal breast tissue, and it is very. These are images, sideways views of the right and left breast. Again, following the convention that I discussed before, we always look as if we are looking at a patient. This is the patient's right side breast looking from the side, the left breast looking from the side. The images are always presented in this way to look for symmetry and asymmetry. I think you can all recognize that there is a dense nodule in the peripheral aspect of the left breast, a little bit above the nipple. This is a breast of an older woman where most of the glandular tissue has been replaced by fat, making identification of this nodule in the left breast relatively easy. The radiologist, in this case, was able to assist the surgeon by placing a wire in the breast into or next to the nodule. This is done after cleaning the skin and putting anesthetic material within the breast tissue, and it's done to help the breast surgeon remove the smallest possible volume of breast tissue to remove this nodule. This next image shows the specimen that has been removed from the patient. Here you can see the needle wire located directly within this soft tissue nodule and this eccentric area of fatty tissue surrounding the nodule. You can see how close to the margin of the specimen the nodule is, indicating how very hard it is for the surgeon to feel this lesion, needing the wire in order to take this lesion out successfully. This turned out to be a benign tumor requiring no additional treatment for the patient. Before we begin discussing cross-sectional imaging techniques like CT, MR, and ultrasound, let's get some reference points to the terminology we use for this imaging. I'm showing you here some scout views. These are preliminary images that are obtained in a CT. The first image is a frontal projection, and the second one is the lateral. Just as we've talked about, when we look at these images, it's as if we're facing a person. That's the right shoulder, and that's the left shoulder. We don't have the same reference on the lateral view. If we take a slice through the middle of this patient's upper abdomen, it would look something like this on the scout image, and this is what we would get. We call this image an axial projection, and the right-left rules apply. So across from your left side is the right side of the patient, and vice versa for the left. We always refer to the anatomy as if we're talking about the patient directly. What about if we slice the patient from the head down the middle? It would look something like this going through the axial plane. This is the image that we would get. We call this a sagittal projection. The only plane that's left is to slice the patient the long way from side to side. In the axial image, it would look something like this. And on the sagittal reference image, we would be slicing the patient in this direction. What we get from this kind of a slice is called the coronal projection. Let's talk about another type of very important study in diagnostic imaging. Let's call them modalities. Computed axial tomography is a sophisticated form of X-ray. It was developed only in the 1970s, a short time ago in medical history. It generates bread slice or cross-sectional images through the body. Often we use X-ray dye or contrast to enhance the blood vessels and the solid organs. It provides exquisite anatomic detail, and it has revolutionized medicine and surgery. The discovery of computed axial tomography was a Nobel Prize achievement for two individuals. How does a CAT scan work and obtain these incredible cross-sectional X-ray images? This is a cartoon or a mock-up of a CAT scan device. Imagine a large metal ring. On one edge of the ring, there's an X-ray source. Across from it are a series of X-ray detectors. We place a patient in the middle of the ring and turn the X-ray machine on, and then spin around. An image is formed by solving equations for the density at each point in space. For those of you who are math inclined, these are Fourier transformations. Doing this math and coming up with this technology were the Nobel Prize achievements behind CAT scanning. I'm sure many of you have had CTs for one reason or another and know what these machines look like from the outside. This is what a CT scanner looks like with the cover off. The parts that we talked about are seen here. This is the X-ray tube. Directly across are the X-ray detectors. You know that the patient slides on the table into the hole of that donut. And the X-ray tube turns on and goes through the patient and irradiates the detectors. Let's see how this device works in real time. That CT scanner is spinning 2 to 3 times per second. And the G-forces on the equipment inside that metal ring are extraordinarily high. That's actually what limits how fast the scanner can spin. Probably wouldn't get into it if you didn't have the cover on it. When we do a CT scan, we're obtaining axial images through whatever body part of interest we're studying. These are slices obtained through the upper portion of a chest. Let's talk about the fact that when we take a CT scan, there's a tremendous amount of data, more data than we can see at any one point in time. A single slice through the middle of the chest can be viewed in soft tissue window. We can see the chambers of the heart. This is the left atrium. This is the root of the aorta. This is the descending aorta, and there are other structures. We can see the muscles in gray. The fat is black. Bones are white. And the lungs, which are filled with air, black. We can take that same exact image and just manipulate the data in a certain way to make the lungs appear more visible. Now we can see detail in the lungs, small blood vessels and airways. Some of the other structures are less well defined. The muscles are hard to separate from the ribs. Yet another display of the exact same data is optimized to show the bones. We can faintly make out the lungs and sort of see the soft tissue, but in this image, we're able to see very well the tip of the scapula on the right, many of the right ribs, the sternum or breastbone, one of the thoracic vertebral bodies. Let's look at another CT example, this time a CT of the head. This is an axial slice through the top portion of the head in a young child. The darker areas in the center represent the white matter tracts. At the periphery of the brain, the whiter areas is the gray matter or the brain cortex. I'm sure everyone noticed that there's this very bright area at the edge of the brain that's elliptical shaped. Is that inside the brain? Is it outside the brain? What kind of problem is it? Let me give you a little history. This is a 5-year-old girl who fell off the monkey bars and hit her head. She's crying and vomiting, and you know something is wrong. Can you figure out anything else from these images? Let me show you a bone image. It's the same image, just windowed differently to look at the bone. Does everyone see the fracture? It's displaced. What do we think this white area is? This is blood. This is an epidural hemorrhage and represents a neurosurgical emergency. This child needs to go to the operating room quickly and have this blood evacuated to remove the pressure from her brain. CT imaging has improved so much in the past decades that we can now take images of the beating heart, freeze the motion of the beating heart, and image the arteries that feed the heart muscle itself. This is the left ventricle of the heart. This is the right coronary artery. coming around the right side of the heart. Even though the heart is beating and moving, we can see these vessels beautifully. I want to give you a sense of how challenging it is technically to image the beating heart. First, we'll do a little bit of cross-sectional anatomy. The front of the patient is here. This is the sternum. This is towards the back of the patient. This is the descending aorta. As usual, this is the patient's right side. This is the patient's left side. The structure here is the right atrium. In front of it is the right ventricle. The left atrium is in the back of the heart, and the chamber with the thick myocardial muscle around it is the left ventricle. The circles show you the various coronary arteries. This is the right coronary artery. This is the left anterior descending coronary artery. This is the circumflex coronary artery. It's amazing that we can get the images that I just showed you, because this is what's happening to the heart in real time. With every beat, the heart is squeezing, rolling, pitching, yawing. The way that CT is able to freeze that motion is because of that fast spinning motion that I showed you with the hood off of the CT scanner. The fast spinning of the CAT scanner is like a fast shutter speed on a camera. It's able to freeze the motion of the heart in time, allowing us to get the extraordinary images that we're able to obtain currently. There are other procedures that are done in CT. Here you can see a needle going into the back of the right lung. The patient is upside down, so this is their right side. There's their spine. This is the left side. There's a nodule in the periphery of the right lung that has a spiculated, irregular appearance. This is a lung cancer in a smoker. Let's talk about another form of cross-sectional imaging, magnetic resonance imaging. This is a form of imaging in which there is no ionizing radiation. In this kind of imaging, the patient lies within the center of a powerful magnetic field. Although the patient cannot feel it, all of the hydrogen atoms throughout the body align with the magnetic field with the North Pole. A radio wave pulse flips the hydrogen atoms on their side, and a second radio signal is given off by the hydrogen atoms as they line up back with the magnet. Its major uses are for neuroradiology and orthopedics, although we certainly use MR in other parts of the body, including the chest, abdomen, and pelvis. This was also a Nobel Prize achievement. You've probably seen MR scanners. They look similar to CT scanners, although they are a little bit bigger. There's a lot of equipment. Let's look at a cartoon of what happens to the hydrogen atoms for a patient outside and inside the magnet and during imaging. In this first image, we have a patient outside the magnet, very happy, and his hydrogen atoms are randomly aligned in space. When we put the patient inside the magnet, all of the hydrogen atoms align with the magnetic pole of the magnetic field inside the magnet. The next step is to apply a radio frequency pulse from the scanner. I'll bet many of you have had MR scans and know that it's very noisy inside the scanner. That pounding and pulsing that you hear is the radio frequency pulse being generated by the scanner to knock the hydrogen atoms from their straight up position to a 90-degree down position. In between pulses, the hydrogen atoms relax and move back to the North Pole alignment position. When they move from being 90 degrees down to straight back up in alignment with the magnet, each little hydrogen atom gives off a tiny radio signal, and the MR scanner listens for that signal, using that to create the image. Absolutely brilliant. This is another kind of MR scanner, a so-called open magnet. Sometimes patients that are very claustrophobic or perhaps very large will be imaged in this kind of magnet, although they usually don't give as good pictures as a traditional standard MR machine. Let's look at an MR study and see if we can figure out what part of anatomy we're looking at and what imaging plane we're using. What part of the body do you think this is? This is an image of the knee. And what plane are we in? We're in the sagittal plane. This is the front of the knee. This is the back of the knee. I know you haven't learned all the bones yet. This is the femur. This is the proximal tibia. This is the proximal fibula. And this is the patella, or the kneecap. Reach down and feel your own kneecap. And make your leg straight like it is in this picture. Is your kneecap as high as this? Probably not. This kneecap or patella is too high. Can we figure out why? Look at this black band. This band connects the patella to the front and top part of the tibia. It's cleverly named the patellar tendon. The patellar tendon is ruptured in this athlete. This football player has had a season-ending injury by tearing his patellar tendon. With the patella high in this position, which one could figure out on physical exam, you probably wouldn't need an MR to know that the patellar tendon is ruptured. But the patellar tendon injury will come along with other problems in the meniscus and other parts of the knee that can be evaluated by MR. What about these images? What parts of the body are we looking at here? This is the brain. This is a sagittal image of the brain, and this is a coronal image of the brain. Do you see the abnormality, something that doesn't belong? Well, there's a large lobular mass centered in the middle of the brain. It's actually not in the brain, it's on the brain. This is a tumor of the meninges, and it's known as a meningioma. And while it's a benign tumor, a tumor this large is likely to have very bad effects on the patient and will be difficult for a neurosurgeon to remove. Let's talk about the next imaging modality, ultrasound. Ultrasound is an imaging process that also involves no ionizing radiation. Ultrasound uses sound vibrations that are too fast for humans to hear. Human hearing is in the range of up to 18 kilohertz. Kilohertz means 1,000 hertz or 1,000 vibrations per second. So humans can hear sounds that are vibrating up to about 18,000 vibrations per second. Ultrasound is in the range of 1 to 10 megahertz or 1 to 10 million vibrations per second. Sound is emitted from a transducer, the device that's pressed up against the body part, bounces off the anatomy of the patient, and comes back to the transducer to form the image. I'll bet many of you have had an ultrasound. This ultrasound machine is a very expensive device. They usually cost about $300,000 to $500,000. And the ultrasound technologist is a very, very highly trained individual. Here's the transducer that she's holding. There's another picture of the transducer emitting sound waves. She's about to do an abdominal ultrasound on this patient. Here's an ultrasound image that should be very familiar. We all recognize this right away. This is a baby. You can see this is the front of the mother's abdomen. This is the edge of the placenta. This black area here is the amniotic fluid. We can make out the baby's brain, the nose, and the lips. We can even see structures like the lungs. And this horseshoe-shaped structure is the heart. This is the diaphragm separating the chest from the abdomen, and this structure is the liver. When we look at a picture like this, most of us have an immediate emotional response. Part of that is because babies' heads are much larger in proportion to their body than adults, and that's something that's pre-programmed into us through evolution to evoke positive emotions. What do you think this might be? 3 structures in 3 sacs? Well, this is very early triplets. Ultrasound also has the ability to identify flowing blood in vessels and to characterize that flow as to direction and speed using the Doppler effect. You all know about the Doppler effect either from physics or just from learning how to drive. You're able to tell when you're in your car, when you hear a fire engine or an ambulance, whether it's coming towards you, the frequency is getting higher, or whether it's going away from you, the frequency is getting lower. The same principle is used in ultrasound to tell what the direction and speed of blood flow is, and it's highly accurate. This is an image of the carotid artery. This is the common carotid artery. This is the external carotid artery, which will feed the face and the scalp and the skull. And this is the internal carotid artery, which is headed towards the brain. We can really measure in great detail the flow in the artery. This is a color Doppler image showing the activity in the center of this blood vessel. And what it's showing us is the heartbeat. You'll probably learn in this class about systole and diastole. Systole is when the left ventricle of the heart contracts and blood comes out of the heart with great velocity and pressure. Diastole is when the heart rests and still blood is moving forward. Then there's another systole. Each one of these would be a heartbeat that you could palpate and hear with the ultrasound. Let's discuss another imaging modality known as nuclear medicine. In typical X-rays and CAT scan imaging, we create radiation and pass it through the patient to create an image. In nuclear medicine, we either inject into the patient or have the patient swallow radioactive material. Then we follow that radioactive activity as it goes through physiologic processes in the body. The radioactivity in the form of photons is emitted from the patient rather than passing from outside through the patient to a detector. There's a special camera, a gamma camera, that captures the photons as they're coming out of the patient to form an image. The computer creates that image and can analyze the data over time. It has major uses in looking at the heart, studying the lungs, kidney function, and in bone disease. These images are from a common nuclear medicine study known as a whole body bone scan. The patient was injected with radioactive material which has an affinity for bone. This image is from the patient's front. This image is from the patient's back. This is another one of our exceptions to the imaging rule we talked about. When we look at this image, this is the patient's right side, this is the patient's left side. When we look at the patient from the back, this is the patient's right side and this is the patient's left side. This hotspot in the patient's arm on the left, near the left elbow, is not an abnormality. It's the site where the patient was injected and a little bit of the radioactive material got under the skin. That's okay. This is a normal scan with no areas that raise concern. This is another patient bone scan that's very abnormal. You can see all of these areas of increased activity in the skull, in the spine, throughout the ribs, in the pelvis, and in the proximal right and left femurs. You can see some of the spine activity better on this posterior image because the spine is closer to the camera when the patient is facing backwards. What do you think this could be? Is it an Ant Mini or is it a differential diagnosis? Well, for me, it's a differential diagnosis that can be informed by a little bit of history. This pattern is very suspicious for metastatic disease. When doctors talk about bone cancer, we mean primary bone cancer, tumors that start in a bone. Now, those are extremely rare. What we're seeing in this study is the spread of cancer to the bones that started in another organ. Well, if we know what the patient's sex is, we can create a very short differential diagnosis to figure out what this might be. So you could say that if the patient were a woman, what do you think the most likely diagnosis would be? It would be metastatic breast cancer. After that would be lung cancer. What about if the patient was a man? The most likely diagnosis would be prostate cancer, again followed by lung cancer. So when we create our differential diagnosis for findings, we always refine it by the other information that we have. A special branch of nuclear medicine is known as PET imaging. This is not imaging of pets like my beloved dogs Jack and Lacey, long gone. PET scanning stands for positron emission tomography. This is injecting radioactive material, usually sugar. Tumor and infected cells use more sugar than normal cells, and they light up very brightly. It's primarily used for cancer and for infection imaging, but there are new agents that are tagged to PET imaging that will expand the use of PET over time. Let's look at a PET scan image, which is typically obtained of the entire body. See if we can identify various structures on this scan. Remember that the PET agent is typically radioactive sugar, and the brain is a big user of sugar, as is the heart. It's normal for some of this tracer to be excreted in the colon, as well as through the kidneys into the bladder. The abnormality in this patient is a mass. What part of the body is it in? Well, it's above the diaphragm and liver, below the neck. We're in the chest. This is the right side and the left side. This mass is in the root of the lung on the right, known as the pulmonary hilum, and it's a lung cancer. You may have noticed I've shown you several cases throughout the day of lung cancer. It's probably one of the most preventable cancers that we have. My single best advice to you that I could give today is not to smoke. We're going to finish up talking about angiography and interventional radiology. This is the branch of radiology where we use needles and wires and catheters, tubes, to reach nearly any part of the body. We do this to biopsy tissue, to sample tissue to look at under the microscope, to drain fluid. Sometimes we want to study blood vessels. Sometimes we want to open arteries that are blocked. Sometimes in a patient, let's say that's bleeding or that has a tumor, we want to cut the blood flow off to that area. This has had a major impact on surgery with interventional radiology procedures, taking a lot of cases and making them into simple, safe outpatient procedures that used to be surgeries requiring long hospital stays. The interventional radiology suite looks an awful lot like an operating room, except everyone is wearing very heavy lead. Let's look at a typical kind of study done in interventional radiology. This is an angiogram of the thoracic aorta. You can see this candy cane-like structure. This is the aorta, branches going to the arms and to the head. This thin line is a catheter that's been threaded up from the groin into the root of the aorta. These small blood vessels that are wrapping around this globe are actually the coronary arteries of the heart. This part of the aorta, the proximal aorta and the arch, is smooth, as is the descending aorta. But there's this area near the arch that's very lobular and irregular. This is a tear, also known as a pseudoaneurysm, in the thoracic aorta. And it occurred in a patient that was in a high-speed motor vehicle crash. Patient was traveling at a very fast speed and hit a wall. The aorta decelerated at different rates and tore. For most patients, they would simply die at the scene. After a few heartbeats, all of the blood would pump out of the aorta and they would die. This patient was lucky enough to have things just barely hold together. In the past, this patient would have to immediately go to the operating room and see if the surgeon could fix this injury to the aorta. It could be very, very bloody, and there was a big chance that the patient could die in the operation. Now, in interventional radiology, we're able to fix this injury to the aorta by putting a mesh graft between the normal part here and the normal part here, and saving the patient from having an operation. As we wrap up, I want to let you know that radiology is a complex field with many different specialties. Not all radiologists are trained the same way or have the same work every day. I'm in a large group that's highly subspecialized, more than 100 radiologists practicing in multiple states. We have radiologists that specialize in imaging of the abdomen and pelvis, radiologists who just work on the breast, who do emergency imaging, work on bone and joints, take care of children, look at the brain and the spine, do nuclear medicine, work on the chest, which is what I do interventional work, and even do special interventional work in the brain and the spine. Lots of different, very specialized areas to have a great career. I mentioned to you that we use computers and networks to move images around. In my particular group, although we're based in Colorado, we take care of patients in Nebraska, in Kansas, in Wyoming, even in Hawaii and other states. And we're able to do this seamlessly because all imaging is digital over high-speed networks. This is sort of a big deal. Medical images are massive. When I think about the size of a typical email, it's around 100 bytes. A single view of a chest x-ray is 4 megabytes. That's equivalent to about 40,000 emails. When we think about a typical CAT scan that has 1,000 images, that takes up 500 megabytes and would be equivalent to about 5 million emails. So this type of imaging and work requires massive, secure, redundant storage systems and very fast and secure networks to distribute this data. Let's bring today's talk to a close by summarizing the role of the radiologist. The radiologist is a doctor's imaging consultant.